55-year-old gentleman came to ER with complaints of high-grade intermittent fever since 1 week, which was associated with chills and rigor, multiple episodes of vomiting and headache.
Can you tell some conditions with patient with chills and rigors fever?
Urinary tract infection.
Okay, most common is urinary tract infection then. Sir, basic MBBS level questions. Filariasis. Filariasis with secondary infection, cellulitis. Okay. Then. Pneumonia can also present with this one. Then pus anywhere in the body. Malaria is another one. Pus is the most important thing. Pus anywhere in the body. When cellulitis comes under that class, then you told malaria. These are the conditions you get chills and rigors, especially malaria. Okay.
Multiple episode of vomiting and headache, myalgia. Vomiting was non-projectile, headache was diffuse and throbbing type of pain, myalgia which is more on the calf muscles.
Okay.
Patient gives history of walking barefoot around his house.
What are the common fevers with myalgia?
Dengue.
Chikungunya, they present with arthralgia and then myalgia, especially in the ankle joints. Any viral fever, especially dengue fever, then leptospirosis. Dengue fever will have severe back pain. Leptospirosis will have severe calf pain and thigh pain. Okay.
No history of abdomen pain, dysuria, loose stools, cough and breathlessness. No recent history of traveling or food intake from outside. Urine output was adequate. For the above complaint, patient went to nearby hospital and done investigation and told him that his platelet was in lower side, need platelet transfusion and transfused 8 unit of platelet.
At what level of platelets you need to transfuse? Doctors transfuse platelets in different hospital, different criteria. But what is the uniform guidelines to transfuse platelet in a patient with thrombocytopenia?
Below 15,000.
Less than 20,000 patient can have spontaneous bleeding. That doesn't mean that we have to transfuse immediately after 20,000 is touching.
Below 15,000.
Below 10,000, most of the patient may require platelet transfusion. Otherwise, patient is having bleeding at any point of time. Suppose the patient is having 20,000 or 25,000, but he is having a significant bleeding, then you will have to transfuse. Okay. Why we are not prophylactically transfusing the platelet? If you know that, you will know the answer of the first question. Why you are not prophylactically transfusing the platelets? Duration of platelet in our body, which is transfused from outside. That means somebody else's platelet will survive in our body only for 24 hours. But in our body, platelets live for, our own platelet live for, what is half-life? 1 month. You are a special person, 1 month platelet in your body. 7 days. Normally platelet live in our body, our own platelet live for only 7 days. After that it will be destroyed. It will be destroyed in which area? Spleen. Okay, so splenomegaly can also increase the destruction. But somebody's platelet we are receiving, that will be destroyed in our body within 24 hours. Why they are destroyed? Why they are destroyed? Immune mediated. See, you are transfusing someone else's platelet that has got an immunogenicity. So that will be destroyed. So by next day it will be removed from our circulation. So we don't transfuse platelet unnecessarily without any major indication like any bleeding or the patient is undergoing some major surgery. So or you want to do a major procedure in the patient like central line. Central line also lesser risk is there. But like that some major procedures you are doing, transfusion is required. Otherwise we don't transfuse platelet at all. Okay.
General examination. On examination, patient was
So what level of platelet they are transfused, that is very important.
The platelet was less than
10,000. So that is an indicated transfusion. Okay.
General examination. On examination, patient was conscious and oriented, well built and well nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy. Pulse rate 80 per minute and respiratory rate of 18 per minute, and BP was 130 by
See,
80.
we are blindly seeing pulse rate in all fevers. What is the importance of pulse in a patient who is having high degree fever? What all clinical clues you get from an examination of pulse?
Usually it should be tachycardia.
Usually all fevers will have a tachycardia. That is known. Okay, then
There is any relative bradycardia.
relative bradycardia indicates conditions like typhoid, dengue, some other rare infectious diseases. Then patients on beta blockers, all these things can be there. That is called as relative bradycardia. Suppose the pulse rate is very, very high than expected. 1:10 is the expected rate. If it is more than that, you suspect carditis. Okay, some heart problem like inflammation of heart, carditis. That can produce sometimes tachycardia. Sometimes it can produce bradycardia also if the conduction systems are involved. So there are a lot of clinical clues you may get from the only examining the pulse. This patient is having headache, vomiting, pulse rate is very low. Then what is your diagnosis? Platelets are very low. What is your diagnosis? This patient is having low platelet. He is having severe headache. He is having raised ICT due to a bleed. You have to suspect. I am not telling that is there, but as an emergency doctor, you should think that okay, there is a chance of bleed. Then bleed, you have to do some clinical examination to rule out a raised ICT, and if required, CT can be done.
Blood pressure of 130 by 80.
Okay.
And oxygen saturation was 95% on room. Systemic examination and gastrointestinal tract inspection. Shape of abdomen was normal. Umbilicus central, no distension. Palpation, no organomegaly or no tenderness.
Okay.
Percussion, no evidence of ascites. Auscultation, bowel sound heard and it's normal. Central nervous system, higher mental function was normal. Motor and sensor system are normal. No signs of meningeal irritation. Respiratory system, inspection, shape of chest is normal. Trachea appears central. Movement of chest appear normal. No dilated veins or scar. Palpation, trachea is central. All adequate movement moves equal with the respiration. Percussion, resonant notes over all lung field. Auscultation is normal vesicular breath sound heard. No added sounds. Cardiovascular system, S1, S2 heard, no murmur. Investigation, his creatinine was for
Before any fever, creatinine is not the first investigation.
hemoglobin.
Normally, we do ask for a CBC, complete blood count, then CRP, then only liver function test, LFT, RFT, CK, all these things will be done.
Hemoglobin was 11 and TC was 12. Platelet was 18,000. Creatinine was 4.9. Urea is 135. SGOT is 94 and SGPT 61.
Creatinine?
4.
4. Okay. Urea is?
135.
Okay. What is the ratio of urea to creatinine here?
Higher.
4 means 20. For every 1, 20 has to add. So 20 to 40. That is, so how much it will come? 4 into 20, 80. Here it is 140. So that is slightly higher than the normal expected range. That indicates what? So he is having a renal failure. Something else also contributing to that renal failure. What is that? If it is a renal damage, that normally reflects urea to creatinine ratio is maintained. If the urea is very high, that indicates what? Pre-renal. That indicates deficit of fluid in the intra. So some patients with this type of urea creatinine ratio, if you give fluids, they may come back to normal. Some patients, not all patients. Some patients already they have pre-existing kidney disease. On top of that, dehydration occurs. That urea increases, creatinine also. Some patients like this leptospirosis, it affects the kidney. On top of that, patient is losing water, so that also add. So it will be a pre-renal plus renal damage. So in that condition, when you are giving fluids, you have to be very careful, because when you give fluid, the intravascular compartment will fill. But after that, patient can develop fluid overload because kidneys are not removing water. So that condition you have to be very careful.
And total bilirubin was 2. Direct bilirubin is 1.5. CRP is 100. Lepto IgM was done. It is positive.
So how many days fever is having?
5 days fever.
5 days fever. Okay. How do you investigate leptospirosis from first day onwards? Somebody coming with fever, severe myalgia, redness of eye. You want to investigate for leptospirosis. What is the first investigation? Urine dark field microscopy. Or you can even do PCR in the first week. Towards the second week, IgM lepto can be positive because it's an antibody testing. Okay. So here lepto is already positive and your clinical features fit into a tropical fever like leptospirosis.
Diagnosis: acute febrile illness, leptospirosis, and acute kidney injury.
Leptospirosis means infection of leptospira to a human being. When the patient develops multi-organ dysfunction syndrome, what it is called as? Wheel syndrome. Okay. So what are the components of wheel syndrome?
Liver damage.
Kidney damage. Myocarditis, pulmonary hemorrhage. Okay, then rarely patient can have altered behavior also. So that is due to what? So what is the difference between leptospirosis and wheel syndrome? There is a main difference.
Leptospirosis in that there is a spirochete infection which is happening. In wheels, it's the immunological reaction.
Okay, so initially patient is having only an infection due to leptospira. Most of the patients will recover without any major damage of the organs. But some patients during the second week or early second week, they go to multi-organ dysfunction syndrome. That is because of the antibody mediated destruction of the organ. Okay, so that can be called as anectric phase and icteric phase. Okay, same thing. Okay, so he is in wheel syndrome. Okay.
We treated him with IV antibiotics. Doxy was there.
What are the antibiotics can be useful in leptospirosis?
Doxycycline.
Amoxicillin. Penicillin. Ceftriaxone. Then azithromycin. Piperacillin tazobactam. Meropenem. Everything is possible. So don't think that only meropenem can cover leptospirosis. You start simple antibiotic like crystalline penicillin that can even kill complete leptospira in our body. So there is no resistance documented for crystalline penicillin so far for leptospirosis. But only problem is when you are treating this patient is already gone to a stage of multi-organ dysfunction syndrome due to wheel syndrome. So whatever antibiotics you are starting, that will kill only the bacteria. It cannot cover the immune mediated phase. So ideal situation is whenever you see a patient, you suspect a patient who is having leptospirosis, you give single shot of penicillin that can kill all the bacteria in our body. Okay, but if you wait for getting the reports of culture, all these things, by the time the patient will have multi-organ dysfunction. Most of the patients come with multi-organ dysfunction during the early second week of the disease. So better to start the treatment very early. You can even give a single tablet of doxycycline orally if you are suspecting like this. Okay. So many a time what happens is you ask for culture, you ask for reports, and by the time patient develops renal disease or liver disease, that will not respond to your antibiotics. So in that case, unnecessarily sometimes we go for higher antibiotics. That is not required. The antibiotics are only to cover the leptospira. Most of the antibiotics are equally effective against leptospirosis. So that we should remember. Then unnecessarily giving meropenem, piperacillin, tazobactam, all these things is not necessary. Only thing, if the patient is on ventilator for some days in a hospital, primary or secondary care center, coming to tertiary care center, if you are suspecting a ventilator associated secondary infection, then only you have to go for higher antibiotic. What is the most dangerous complication of leptospirosis? Most common complication is renal failure. Most dangerous complication?
Pulmonary
Pulmonary hemorrhage. So Most of the leptospirosis cases, what you are seeing in X-ray as ARDS, that may not be ARDS. They are pulmonary hemorrhage. So when you are intubating itself, you can see that blood is coming from the tube. If the blood is coming from the tube or you suspect pulmonary hemorrhage, then the mortality rate is very, very high. This is the one condition in leptospirosis, very, very high mortality. Comparing to other, even the patient is having renal failure, if you do 1 or 2 weeks dialysis, they recover completely. But pulmonary hemorrhage recovery is unlikely because large amount of blood is there in the alveoli. So that we have to be very careful. What happened to the patient?
Patient was discharged now, sir.
No, how do you treated the renal failure?
Renal failure?
Any dialysis required?
No, sir.
There was no
Urine output was normal.
maintained. Okay. Then any requirement of BiPAP or ventilation?
No, sir, no, nothing.
X-ray was normal?
X-ray.
X-ray was normal. Only patient developed renal failure.
Renal failure.
So when you give fluids, most of the patients will recover because there is a component of pre-renal failure also here. And when you treat the existing bacteria or spirochetes, the further initiation of antibodies against the kidney or whatever it is, the rate can come down. Okay. Then rest all things depends on your body immunity. Body immunity means what type of immune reaction it is. So a very healthy person also develop multi-organ dysfunction. So what is it? Is it low immunity or high immunity? What it is called as the term used for this is what? It is immune dysregulation syndrome. Okay. So a healthy person is developing all this problem. That is because of his immunity is dysregulated. Normally whenever we have an infection, our body will try to control the immune mediated inflammation. Otherwise, the inflammatory cells can even kill your body cells. So for that, we have a mechanism. Our body will try to control the inflammation. That is a regulated inflammatory response. But here, due to some reason, unknown reason, there is a dysregulated immune attack. Sometimes this is called as antigenic mimicry. Okay, where all you see this antigenic mimicry? Very common. Rheumatic fever. Rheumatic fever is the classical example for antigenic mimicry. Streptococci infection, there is an antibody produced against that streptococci. That antibody, they think that your heart cell or your joint cells are a a foreign cell like your bacteria. They try to destroy that cells. Okay. So that is a classical example for antigenic mimicry. Here also something like happens, we call it as immune dysregulation syndrome or macrophage activation syndrome. What are the classical examples of macrophage activation syndrome? It's not exactly macrophage activation syndrome. At one point it turns to macrophage activation syndrome. Till then we call it as simple multi-organ dysfunction. What are the components of macrophage activation syndrome? You get dengue fever, we see it. What is the most important investigation we do routinely to diagnose that? Ferritin level. So whenever there is a high level of inflammation, normally we do CRP. CRP is high. If it is dengue, if the patient is very sick, then we ask for a ferritin level. If ferritin is very high, that's an acute phase reactant. Ferritin levels are very high, then we suspect macrophage activation syndrome. Some type of macrophage activation syndrome, you can see very high cholesterol, liver function test will be damaged, PTNR can be elevated. It's also a multi-organ dysfunction syndrome, but it's the another spectrum of multi-organ dysfunction syndrome or the last type of multi-organ dysfunction syndrome, highest level of multi-organ dysfunction. So this patient has not developed all these things. He recovered without any problem. And how do you follow up this patient?
So we gave
What are the advices you give for this patient? How to prevent leptospirosis? That is very important. What is his job?
He's no job, sir.
No job means what? Some job has to be there, no?
Retired person.
How the leptospirosis spreads from reservoirs to human body? That is very important. If you educate them, next time he may not come with leptospirosis. How it spreads?
Urine of a rat.
Urine of a type of rat, huge rat. Okay, that's a rodent. From that, it will contaminate the water. When you enter that contaminated water with wounds in your leg, it can spread through that wound and get inside your body. Okay, but if you see many patients Leptospira IgM, it will be like sometimes positive. You see many patients with dengue, you are investigating. Sometimes you know that it is not Leptospira, but if you do an investigation, it will be positive. 1 in 10, I think it is more than 1 in 10 is positive. So what it indicates? It's a previous infection. Many patients you are seeing here coming with various type of fevers, them all the Leptospira may be slightly positive. That doesn't mean that they are actually Leptospira positive. Either they have a past infection or there are a lot of other spirochetes. They have similar feature of Leptospirosis, but they are not pathogenic like Leptospirosis. There also you can get some mild positivity of Leptospira IgM. So that also you have to keep in mind. Sometimes in dengue fever you can see Leptospira is mildly positive. That doesn't mean that the patient is having Leptospira. Even then, when you are seeing like this, just one tablet of doxycycline can kill all the bacteria. We can avoid unnecessarily complication in that patient. Scientifically it may not be correct. We cannot give all the patients doxycycline, but practically, when you are suspecting a fever with myalgia, the Leptospira being the second or third differential diagnosis, you can give a doxycycline and save the patient's life. Nothing wrong in that. Okay, anything? No doubt. Okay, thank you.
Thanks.